Dear friends, in this video, I am going to talk about the different considerations for ventilating a brain-injured patient. Let us start with this case scenario. A 30-year-old male, a victim of road traffic accident due to polytrauma, presents with loss of consciousness and fractured both bone of the forearm. On examination, his heart rate is 110, blood pressure is 100/60. The chest, CVS, and abdomen are normal. But in CNS, the GCS score is 6, E2, V2, and M2. The deep tendon reflexes are brisk. The superficial reflexes are diminished, and the plantar is flexor. The chest X-ray reads normal. And on CT head, there is diffuse axial injury with no midline shift and no signs of raised intracranial pressure. But in view of poor GCS, the patient needs to be intubated. Now, the first question that arises in this scenario is that can we try rapid sequence induction for intubation in these patients of traumatic brain injury? Well, the issue of rapid sequence induction in traumatic brain injury patient or acute brain injured patient is complex because most of the drugs which are used for before performing rapid sequence induction are likely to have an effect on the hemodynamics of the patient. So in patients who are at risk of hypotension or who have existent hypotension, in those patients, no pre-treatment or pre-treatment medication can be given because it will alter the hemodynamic status. And if there is further fall in the blood pressure, the blood supply to the brain gets affected. So in the hypotensive group, we avoid, but in normotensive or hypertensive population, a small dose of fentanyl bolus can be given. If the patient requires some anesthetic agent, then in the hypotensive group, it is preferable to give ketamine, whereas in the normotensive or hypertensive group, an etomidate can be a choice which can be used to avoid or minimize hemodynamic fluctuations. Succinyl-choline is the muscle relaxant of choice in either case, whereas post-intubation for sedation and analgesia, a hypotension patient, hypertensive patient, or who has a predilection for hypotension can be treated with a combination of midas or fentanyl or dexmed and fentanyl. Whereas for normotensive patients, in addition to those or instead of those, we can use propofol also as an infusion. So the entire issue of rapid sequence induction is dependent on the condition of the patient and the risk of hypotension, and that hypotension which can further aggravate the likelihood of further worsening the traumatic brain injury. So therefore, medication administration for rapid sequence induction in a patient with traumatic brain injury is controversial, and hence it may be a good idea to avoid that. So for rapid sequence induction in traumatic brain injury, if the patient is on full stomach or for any other reasons where the rise of intracranial pressure is not expected, in those situations, with the choice of agent will again depend upon the concern about hypotension. So the pre-treatment is avoided in such patients who have a risk for hypotension, whereas fentanyl can be administered 3 minutes before rapid sequence induction if required in normotensive or hypertensive patient population. As I said, for induction, the ketamine may be a suitable choice in view of potential hypotension, whereas etomidate can be a suitable agent in normotensive or hypertensive patients. The paralytic agent of choice is same in both cases, and maintenance of sedation analgesia can be maintained with midas for plus fentanyl or with dexmedetomidine plus fentanyl in patients who have a risk for hypotension, and in the patients who have normotensive or tendency for hypertension, addition of propofol can be considered. But however, all this has to be individualized because there is no absolute recommendation or guideline which tells that which drugs or which agents to be chosen specifically in patients with rapid sequence induction in traumatic brain injury. One thing which we have to remember is that patients with traumatic brain injury are extremely sensitive to changes in the hemodynamics, and changes in the hemodynamics can have a variable effect on the cerebral perfusion and the intracranial pressure. And therefore, it is important to look into the drug and its likely effect before using them for the purpose of rapid sequence induction. The next question comes is after intubation is what should be the initial ventilator settings? We know that both hypoxemia and hyperoxia are dangerous in patients with acute brain injury, and hence both should be avoided at any cost. The optimal targets for PaO2 in patients with acute brain injury who do not have a clinically significant ICP elevation can be 80 to 120, and those for PCO2 in patients with acute brain injury who do not have a clinically significant ICP elevation is 35 to 45. Both are strong recommendations based on low quality of evidence. Regarding the choice of mode, one can go for any mode as per the European Society of Intensive Care Medicine Consensus Declaration of 2020. But if we find into the evidences, scroll carefully into the literature, we find that there has been comparison of the modes, particularly with regard to pressure regulated volume control versus SIMV, where it has been seen that using PRVC mode might be more desirable than using SIMV mode in patients with traumatic brain injury due to better stability of ventilation and oxygenation. However, this study was conducted in an extremely controlled setting, and the numbers were also limited, and therefore it can be very difficult to extrapolate the results of the study into a wider patient population. But definitely we can consider this, and till we get further studies which elaborate further in bigger patients, we can take this lesson that maybe PRVC mode may be more suitable in certain patients populations. Another study which looked upon a comparison of pressure control and PRVC in patients with a traumatic brain injury and tried to see the intracranial pressure, found that the mean intracranial pressure and PCO2 were similar for both the modes, but PRVC ventilation resulted in less fluctuation of both ICP and PCO2. However, the conclusion could not be made because the impact on ICP in patients with higher ICP in patients with higher ICP values can change. So, and the similar PCO2 arguments where observations were argued against this, but still some amount of positive results were seen in these two studies to suggest that PRVC mode may be slightly better in comparison to other modes if chosen appropriately in the appropriate patients. So some studies have observed these benefits, but absolute recommendations still don't exist, and we can use any suitable mode for ventilating them. So let us walk along this case. We have chosen volume control assist, an FiO2 of 70 with a tidal volume of 7 ml per kg, respiratory rate of 12, sensitivity of 3, and after 6 hours, the ABG shows a PCO2 of 46.4, the pH is normal, bicarb is high, PO2 is 150, and other conditions are unaltered. So the neurosurgeon opinion has confirmed that there is no active surgery required for the patient and conservative treatment has to follow. Now, in such a situation where you find that it is becoming the pH is becoming slightly turning alkalotic with a rising bicarb, the question arises, what changes in ventilatory settings should be done? Now, two things should be known very clearly is that the brain glutamate metabolism during both metabolic alkalosis and acidosis are affected. And whenever the brain glutamate metabolism is affected, the cognitive function gets affected. Besides that, the serum bicarbonate concentration and the cognitive function are also responsible for changes in hypertensive adults. That is, if a patient is already hypertensive, an increase in the serum bicarbonate concentration following metabolic alkalosis can produce a decline in the cognitive function. Therefore, both reduced glutamate level turnover leads to cognitive decline and organ dysfunction, as well as a rise in serum bicarbonate concentration can lead to cognitive function disturbances in hypertensive patients. So it is very important to try to restore normalcy and keep the bicarbonate to as near normal as possible, which can be possible in a ventilatory settings. The other important thing that needs mention is that often we see that the first hit with which the patient comes or presents initially abates over a period of time. That is contusion, the diffuse axonal injuries, the cerebral ischemia, they gradually recover. The neuroinflammation progresses, and there is cerebral inflammatory environment which extends to produce a situation of systemic inflammatory environment. And as a result of crosstalk between the brain and other organs, there are changes in the other organs leading to manifestations in the lungs, heart, etc. So this produces high risk of infections. This produces high risk of bradyarrhythmias, cardiogenic shock, etc., all of which can influence the cerebral perfusion pressure by either decreasing it or increasing it, and can produce secondary brain changes, and thereby all the changes which had abated during the after the first hit can actually reappear. So whenever a patient continues to be in a state of inflammation, the inflammatory markers are high, the patient remains hemodynamically unstable and on ventilator, the risk of second hit persists consistently. And this produces a crosstalk between the brain and other organs, giving rise to its damaging effect on the systems which were not affected initially. So let us see that on day 2, the patient, there is no improvement in the neurological status. Patient is hemodynamically stable. There is some amount of respiratory alkalosis, as you can see. And on the CT head, there is diffuse ischemic changes, no midline shift, no cerebral edema, and patient is hemodynamically stable. But now what would be the effect of this metabolic change on the patient? Now, if this patient is hyperventilating to produce this respiratory alkalosis, and the hyperventilation is a central effect in most of such patients, can we use sedation or muscle relaxants in such patients to abate that? We know that hyperventilation is associated with a lot of adverse effects, both systemic and cerebral. Systemic primarily involves the lungs, heart, the abdomen, the kidney, as well as in the blood, in the platelets and the electrolytes. In the cerebral circulation, it affects cerebral it causes cerebral vasoconstriction, so reduces the cerebral blood flow, reduces the cerebral blood volume, and has a propensity to cause brain hypoxia. It increases the neuronal excitability, so it can lead to the trigger the seizures. It reduces also the epileptic threshold and increases the release of excitatory amino acids, increases the dopamine, and altered membrane cell synthesis. So all are the consequences of hyperventilation, giving rise to a fall in PCO2. And therefore, short-term treatment with muscle relaxants in combination with appropriate sedation, wherever possible, should be considered in mechanical ventilated patients who have concurrent acute brain injury and ARDS, particularly when they are being ventilated for prolonged period over a period of time. This is a strong recommendation, despite of having no evidence, and a good practice statement as per the European consensus. As we progress, on day 4, the patient has mild improvement in the neurological status. It is E3M4-VT. The chest, however, shows coarse crepitations with reduced breath sounds and increased secretions, and the lung ultrasound showing V lines in the right lungs with consolidation without any effusion. The counts rises with predominant polymorphs. The ABG shows respiratory acidosis. So what about and how to implement lung protective ventilation and when to increase the PEEP? So this is something which needs to be understood, because these are the patients which, if not intervened at appropriate time, can give rise to ARDS subsequently. So this should be based on both ARDS and ICP elevation risk, that is acute brain injury without ARDS, without clinically significant ICP elevation, can be applied the same level of PEEP as in patients without brain injury. However, when there is concurrent ABI and ARDS without clinically significant ICP elevation, one can think about lung protective ventilation. Traumatic brain injury without ARDS and clinically significant elevation, that is PEEP insensitive, that is PEEP produces no further improvement, we can give same level of PEEP as used in patients without TBI. Whereas in patients without ARDS with clinically significant elevation of ICP, there is no recommendation and no evidence. So these patients have to be treated as on individual case by case to case basis. But patients with concurrent TBI, ARDS, and clinically significant ICP elevation also are bereft of any recommendation, and therefore their treatment or strategy should be also guided on a case-to-case basis. If we see subsequently on day 6, the patient's neurological improvement is much better. E3M5VT, the chest secretions are reduced, air entry is still reduced, with crepitations are less, and patient is hemodynamically stable. In volume control assist and a tidal volume of 450, the patient is breathing adequately with an ABG which is reasonably normal. PO2 is 90, saturation is 97, and bicarb is also near normal. Now, in this scenario, can we start weaning and then follow up with extubation? Now, always one should be guided by the expected clinical trajectory of the underlying condition. And if the underlying condition has resolved, then it may be a good opportunity or a good situation to try weaning and followed by extubation. But neurological status should be accounted for and should be remaining the most important factor to make the decision to wean. The decision to extubate should also account for the presence of or the adequate return of airway protective reflexes, the cough, gag, and the swallowing reflex. There are currently no recommendations regarding any specific GCS threshold to be considered in the decision to extubate mechanically ventilated acute brain injured patients. So the overall neurological improvement, apart from GCS, can be well chosen to guide the patients towards weaning and extubation, again, in an individualized manner on a case-to-case basis in the absence of recommendations and guidelines. But one should know that the weaning failure is much more common after acute brain injury, and any subtle improvement in the neurological level of consciousness should not prompt for instantaneous weaning followed by extubation, because that will only lead to reintubation and increase the risk of all the complications that are associated with re-extubation. So across all the modes, it has been found the chances of weaning failure is higher in patients with acute brain injury as against non-brain injured patients. Now, if this continues for a long time, then definitely we will have to think about elective tracheostomy. So what should be the considerations for elective tracheostomy in such patients? So this elective tracheostomy should be considered in patients with acute brain injury who have failed one or several trials of extubation. And the patients, most importantly, should have a persistently reduced level of consciousness over the entire period of mechanical ventilation. The timing of tracheostomy varies considerably across countries and even among the medical institutions within the same country. And this depends considerably on local practices and policies, and therefore they should be adhered to. And of course, individual case-to-case analysis has to be meticulously done before they're implemented. So there is no consensus or guidelines and to when to start for tracheostomy. Of course, the general consensus that if longer period of mechanical ventilation is anticipated, it is probably good to go for early tracheostomy, although there is no guarantee that there is any improvement in the outcome for early versus late tracheostomy. So now let's go into the case. Day 15, the patient has been tracheostomized. The mechanical ventilation patient is alternating pressure support with volume control assist with a PF ratio less than 100. Neurologically, the patient is E4, M5, and VT. The CT head shows small infarcts. The chest shows consolidation with ground glass opacities on chest X-ray, and ABG shows a mixed disorder with chronic metabolic acidosis and metabolic alkalosis. Now, this situation is very common because after a certain time, whatever lung injury has occurred as a result of second hit, that also shows signs of resolution. The first hit has already resolved significantly, but the lung, after resolving certain, it doesn't tend to heal adequately to enable weaning or from the mechanical ventilation even after tracheostomy. So in those patients, what is the role of rescue therapies? So rescue therapies, we mainly concerned about two things. One is prone positioning and another is ECMO. Now, both of them are difficult in patients with traumatic brain injury for multiple reasons, not just one reason. And both in terms of logistics or in terms of implementation or in the procedure, because all of the both these methods involve techniques which can actually affect the blood flow to the brain. So prone positioning studies have found may be considered in mechanically ventilated patients who have concurrent, moderate, or severe ARDSs with a PF ratio of less than 150 and ABI, but do not have significant ICP elevation, because we know that raised ICP is one of the contraindications to prone ventilation. So this may be a consideration, although the evidence is very limited. And also with ECMO or ACER in acute brain injury patients with severe respiratory failure, evidences are grossly limited. So besides some case series which shows variable results while evaluating ECMO in patients with both ABI, acute brain injury, and ARDS, they reported that none of them reported serious neurological complications. But in the absence of any consensus or guidelines, it is good to avoid such for rescue therapies unless there are very specific reasons to experiment with them. So we can have three sets of patients. One, those with pure acute brain injury. Another with patients in whom the brain injury recovers or resolves, but the patient's lung conditions as a result of second hit persists, which gives rise to varied manifestations of ARDS. And the third patient who have a combination of both, that is, who have both acute brain injuries and also have ARDS. And therefore, the recommendations or the objectives of the tidal volume, the PEEP, the recruitment maneuvers, prone positioning, ECMO are all changes accordingly depending upon the situation. However, the ventilatory targets for acute brain injury remains to maintain adequate oxygenation and normocapnia and to avoid hypercapnia at all costs. The same target applies for ARDS. Maybe the PCO2 is valid to a lesser extent, and any PCO2 can be considered if as long as pH is more than 7.25. The upper limit of PO2 is also reduced, and a range of 55 to 80 is good enough in patients with ARDS alone. However, in patients who have both acute brain injury and ARDS, it is good to maintain a PO2 of on the higher side, that is more than 75. Also to institute protective ventilation and normocapnia or based on neuromonitoring and pH level. So hypocapnia is again an important step which needs to be prevented. So this is in a rough shell the basic steps one can follow while ventilating a patient with brain injury. Although this is not complete, but this gives a scientific sketch to an impression and creates an impression on what should be avoided and what should receive a priority. Thank you very much.